section is focused on eating disorders for behavioral science and psychiatry for Falcon Physician Reviews. There are two main eating disorders that we're going to focus on in this next section, and they are anorexia nervosa and bulimia nervosa. So anorexia nervosa is the failure to maintain body weight of 85% of ideal, as well as preoccupation with and fear of gaining weight, amenorrhea for 3+ cycles, and an unrealistic influence of body weight on self-esteem are the main diagnostic criteria for anorexia nervosa. So there can be two types. There can be the restrictive type and the binge eating purging subtype. But how would you differentiate the binge eating purging subtype from bulimia is the four main criteria that you had earlier, with the 85% of ideal body weight, the fear of gaining weight, not having your menstrual period for 3 cycles, and an unrealistic influence of your body weight on self-esteem. Whereas you won't have those criteria for someone with bulimia. Anorexia occurs much more commonly in women than it does in men. A differential diagnosis will be body dysmorphic disorder. In body dysmorphic disorder, generally it's about one part in specific. It'll be your nose, it'll be your back, it'll be your fingers, but it won't be your entire body image like you do have in anorexia nervosa. Major depressive disorder, some people don't eat very much because they're depressed. You want to rule that out. Medical conditions, there's a lot of weight loss. And again, bulimia nervosa, they have body image concerns, but they're generally of normal weight. Risk factors, there's a huge cultural emphasis on thinness. If we look at all the magazines nowadays, it's all about how thin people are getting, how do you get even thinner, how do you lose weight. So it's very common in industrial societies and in higher socioeconomic classes. Other risk factors include an emotional conflict with one's body image, perfectionism, family control or sexuality, frequently found in families where there's a lot of conflict between mother and daughter. Patients will have a lot of anorexia nervosa. And also you will see this frequently when girls are going on into a new stage of life, like when they're graduating high school and they're starting college during these stressful events, maturation into being a woman. These are frequently times when you will notice anorexia nervosa will pop up. Frequently there is also a history of physical or sexual abuse. So how will anorexia nervosa present to you on the exam? It'll be usually a highly driven young female who's on the track team doing really well in school, who is obsessing about food and you don't really see her eating. She's increasing her exercise, exercising 4 or 5 hours a day, but really decreasing her calories. And what you'll look for in your vignette is also signs of starvation, such as a BMI of less than 18, bradycardia is a key factor, temporal wasting, electrolyte abnormalities. They'll have abnormal potassium, and that is the #1 abnormal electrolyte in anorexia nervosa is the potassium, and that is an exam question. They will have hypotension, amenorrhea, and anemia. The problem with anorexia is that it's very, very difficult to treat, and generally people will backslide and need several treatments before that they can get better. You have to first manage their medical complications and refeed them. Watch out for ipecac toxicity in patients who have a purging history, and they will use that to help them vomit. Once you have treated once you have treated the medical issues and you have done the refeeding, then you can really start working on the therapy about why they don't feel like they should eat and the family problems that they have. Also, antidepressants, especially fluoxetine or Prozac, have been shown to be helpful, that once you maintain a normal weight range, that it can help maintain it. Next we have bulimia nervosa, and bulimia has several symptoms that are similar to anorexia, but the difference is in that bulimics is that they are an ideal body weight. They generally are not below the normal body weight. They will have their periods, but they do have an intense fear of gaining weight. They have an abnormal body image. They have a purging type and a non-purging type, and where you can have patients will fast or exercise for long periods of time, but they don't use laxatives or self-induced vomiting or diuretics. Bulimia has a prevalence of about 1 to 3% of women, and it's much more common than anorexia. Also, again, this is much more common in females than it is in males. And bulimics will also have an increased risk of borderline personality disorder, as well as an increase in drugs and alcohol use. Same differential diagnosis for anorexia. Clinical presentation look very similar to anorexia. They don't want to get fat, they don't want to gain weight, but they'll be a normal body weight. And they'll also have very similar medical problems because they'll be vomiting, so you have to watch out for hypochloremic metabolic alkalosis, look for potassium abnormalities, and these things can be very life-threatening. How do you manage it? Cognitive behavioral therapy is the most indicated treatment for bulimia, followed by medications, and group therapy and family therapy can also be helpful. And bulimia is actually a little bit more successful in treating than anorexia. This concludes our section on eating disorders for behavioral science and psychiatry for Falcon Physician Reviews. This concludes our section on eating disorders for behavioral science and psychiatry for Falcon Physician Reviews.